Hey, boys and girls, how you doing? So here we go. We're going to go ahead and get started with this. Here's how I'd like to do it. I'm doing with my high school classrooms is I'm opening up the PowerPoint that we'll go through. You guys, I'm going to ask you guys to take notes, okay? Because that was something I think is going to be very valuable to you in the long run, making sure you have those notes with you before you take your national registry. So I'm going to ask you, we're going to continue the same thing, just take some notes. When I am done, I'm going to chunk this into pieces. I'm not going to do everything all at once with you guys. I'm going to break it down into two, three, in some cases, maybe four separate lectures as we went through the materials. When I'm done, I will load up the entire PowerPoint as well. So you'll have my video sections and you'll have the entire PowerPoint at your disposal. But we're going to go ahead and start out with behavioral emergencies, and we're going to run through this just like we do in class. The difference is you're not here with me. So, case study, we're going to come back to that. You guys will see that in the video lesson. So we're talking behavioral emergencies. Behavioral emergencies, as I got it written down here, what is behavior anyways? Behavior is a person's activity and response, especially that which can be observed. So, normal everyday behavior would be considered what we call normal, okay, appropriate behavior. But when people are acting outside that norm, unexpectedly, intolerable, or to someone else, that behavior becomes behavioral emergencies. It's kind of interesting to think, though. I mean, these people that have psychiatric issues, are they really the ones that have the problem, or is there just an underlying issue that's got to be dealt with? And that's really what it comes down to. But behavioral emergencies are unacceptable or intolerable situations that arise with other people. They can't manage what other people are acting like. So behavior is your actions, your activity, your responses, and then behavioral emergencies are the unacceptable and intolerable portions of that. Mental illness is a disorder or thought, mood, perception, orientation, or memory that impairs judgment, behavior, recognition, and reality, or inability, or ability to complete activities of daily living. So when we talk about mental illness, these people are unable to function normally throughout their normal day. And so as you start going through, you get into the field and you start seeing these types of things, you start to recognize there's definitely some traits that we need to be aware of and understand when it comes to behavioral emergencies. Changes that may cause behavioral emergencies. Low blood sugars definitely can be mistaken for psychiatric issues. They are behavioral changes. You're no longer acting normal. If your blood sugar drops too low, you're confused, you're altered, you're making some unusual decisions. Hypoxia, lack of oxygen to the brain, to the tissues, not going to work well. You can't function properly. Inadequate blood flow to the brain. Same thing. We're lacking oxygen and nutrients to the brain. It's not going to function right. A head trauma can make us cause us to act oddly and act out. We need to be aware of that. Pay attention to that. Mind altering substances, obviously any kind of drug, alcohol and or drug that you're taking that alters your perception, alters your mind, can become that behavioral emergency. I'd say if I'm going too fast, tell me to slow down, but you can't do that. And the fact is you can pause it and do what you need to do. Behavioral changes may be caused by psychogenic substances, excessive cold or heat, infection to the brain or its covering. The seizure disorder could be trigger behavioral issues. And I'll give you a quick story. We talked about the fact there's all types of different seizures. And so we can mistake seizures for actually people with mental disabilities. It's a behavioral issue that's actually going on. And honest to God, this happened in the emergency room. A patient was given some medication. That medication was necessary for them. For the condition they have, but we found out later they were allergic to that medication. The patient didn't even know that either. What actually ended up happening was, honest to God, the patient got up out of bed uncontrollably and started dancing. I mean, it wasn't really dancing, but they, moving all over the place, they couldn't stop. It really was odd. Definitely looked like a psychiatric type situation, other than the patient was able to kind of explain, I don't know what's going on, I can't stop it. And after some, discussion and a little bit more research, the doctor realized this was a seizure disorder that was actually happening to that patient. It's kind of really unusual. toxic ingestion or overdose, and withdrawals from drugs or alcohol. That's actually something that's very interesting. We all understand withdrawals as coming off of a substance, and you can withdraw from anything. If you use anything in excess and stop suddenly, you go through withdrawals. It doesn't matter what it is. If you enjoy sweet tarts and you're eating those all the time and you stop for a period of time, you're going to want them. But the difference is some of these things actually cause more physical harm. Heroin is one of those types of drugs that when you do not have that drug with you, if you use it and you don't have it, it can kill you from coming off that, going through the withdrawal. Another one people don't realize, though, is alcohol. It's called delirium tremors happen from this. As you withdraw from alcohol, you go through what's called delirium tremors. Very psychiatric patient type situation. And these patients are at high risk of death. And unfortunately, in some cases, the only way to treat with delirium withdrawals is more alcohol. The only way you can actually manage them. Always consider that an apparent behavioral problem may have a physical cause. What we're saying here, just like I've talked to you before, when we talk about patients who have psychiatric issues, who may have them, we have to look at medical underlying problems first. A patient with a head injury may present like a patient who is psychotic at the moment. And we can't treat them as if they're psychotic. We need to treat them as if they actually have a medical problem. We need to treat the head injury. Diabetic, low blood sugar. We should understand right now that if low blood sugar gets too low, they will die. If we assume that they're behaviorally having an issue and we don't treat the low blood sugar, then we've got a whole new problem in our hands. We've got a possible dead body. So we need to treat physical underlying causes first before we start considering the behavioral problems. Drugs and assessments may pay attention to the following. When we're doing, during the assessment, pay attention to the following. I would love to tell you that I have problems speaking at night only. Obviously, you can tell that's not true. General appearance and demeanor, grooming, build, and behavior. When you see patients, I mean, we know a person who's ill, a person who's sick, doesn't feel well. They don't present normal. You're going to walk in, they look disheveled, a mess, falling apart. But you need to look further. Look at their nails. Look at the grooming of their feet, their hands. How long their nails are? Are they clean underneath them? Their hair, is it a mess? Is it knotted up? Even their surroundings. Take a look at their overall surroundings, personal hygiene. All these types of things can tell us behavioral emergencies. People who have these problems deal with them on a daily basis for a long time, and it causes problems for them in the long run. During the assessment, we might see some of the following. Speech. Their patterns may be rhythmic. They may be monotone, or in some cases, they're not connected to you in that conversation, basically. Slurring their words, they kind of sound like they're drunk. They having some mental issue, and this may be causing some slurring of words. Their word choices overall, they may be making some really odd comments and not putting things together correctly, or not really answering your questions the right way. Appropriateness of the response, again, their answers may be wrong. Their answers may be inappropriate. They may be talking to themselves, kind of thing. You want to pay attention to that type of stuff. Pressured speech, where we actually get people that are working hard to try and get something out. I mean, we're pressured. They feel like they're being pressured to kind of conversate, and this can be a very struggling thing for them and cause them to actually increase that behavioral problem. We want to look at skin, color, temperature, condition. This is a normal thing. This is going to give us some of the underlying medical causes, possibly. If we see someone who's cyanotic in the lips, in the fingernail beds, we're looking at hypoxia. If we have someone who's flushed and red, we might have a heat-related emergency. And tacky skin, sweaty. It can lead us to all kinds of possibilities of other things outside of the behavioral emergency, although it also could be related to the behavioral emergency. Posture or gait, look for unusual movements. Now, gait, if you don't know, is your walk, the way that you walk, how you move across the room. And so this gait may be a little bit off. You may be stumbling a bit, and your posture overall. Now, posture, how you sit in a chair, how you present yourself. is definitely something we're looking at, because that can tell us when we've got someone who's withdrawn, who is fearful, scared. They're tucked away, knees drawn up to their chest, sitting in a chair, rocking. Or maybe you got someone who's sitting on the edge of a chair, has their feet flat on the ground, their fists clenched beside them. This is giving us a good indication that they're very, very fearful of their surroundings and willing to do what they need to do to protect themselves. Orientation, person, place, and time. We always talk about four. Who are you? Where are you? What day is it? And who's the president? And so in these questions, we want to make sure that they're able to answer these four. Here, I've mentioned this to you before. Here, they're talking three: person, place, and time. And we've covered that plus adding one extra. It depends on the organization, the company you work for. Some will say orientation of 3 is acceptable. Some will say orientation of 4 is acceptable, meaning that they can fend for themselves, they can care for themselves. Whatever your company suggests, that's it. But orientation, we're going to check that. If a person is able to tell us, in this case right here, we see on this PowerPoint, who they are, where they are, and what time it is, if they can give those 3 answers and they don't want our help, then by all means, we have to start really looking at an AMA and walk away from the situation. We don't run away from the situation. We're going to go through the steps to make sure everything is okay and safe for them to be where they're at. But in that behavioral emergency, even in some cases, even though they can answer all 3 or 4 questions correctly, there may still be an underlying cause for us to actually stay and help. We can't walk away. Next slide. Okay. Body language, threatening gestures, and expression. As I talked to you earlier about, you come in, you happen to see that person sitting on the edge of the chair, feet flat on the ground, fists are clenched in their lap or beside them. Maybe they're standing, and when they're standing, you know what that's like. I mean, shoulders are back, chin is up, chest is puffed out. These are presenting as threats. And when a person is behaviorally threatening physical altercation with their body language, we need to take that into consideration. That is definitely something we want to be careful about. Don't put yourself in a bad spot, because it can get really bad really fast if you're not careful. Their expression, you can see it on their face when you ask certain types of questions. Or in some cases, we may need to let them know exactly what it is we're here to do. And in that respect, that expression is going to change. Pay attention to that face. Keep your eyes on the patient at all times. So things start to change, you need to be prepared. Perception and thought content. Organization of thoughts. We want to make sure that these people they're able to organize and put together their thoughts properly. I mean, everyone has trouble from time to time, but behavioral emergency patients, they tend to have that much more of a problem. Indication of hallucinations, delusions, phobias, rapid shift in topic, and repeated words. We're going to start to notice these things. They're going to clue us into these behavioral emergencies and something that we may need to look at and start to address. Next slide, please. Anxiety, state of uneasiness about impending problems, characteristics characterized by agitation and restlessness, and includes panic attacks. And some of us may have actually gone through some of this before, or know someone who does go through these types of things. These are real. These are real issues that people need to treat. In some cases, just talking this out with a psychologist, psychiatrist can help, but in other cases, medication is required. And when these people are on a medication specifically for anxiety and now don't have the medication, it's going to light off, and we need to be aware of that. Panic attacks, again, some of us may have had this before. It's a sudden onset. It lasts for about 10 minutes or greater. Palpitations, sweating, trembling, shortness of breath, derealization, fear or loss of control or dying are some of the senses that they're going to have. Palpitations, a fluttering in the chest. The heart starts to flutter. And that's when you've got PVCs happening, or more or less you've got, a rapid heart rate, really is what we're looking at in this case. May be accompanied by hyperventilation. And so that panic attack, if it goes too far, ends up in that hyperventilation. We should understand hyperventilation is an increase of oxygen into the body, meaning that the patient is unable to really control the amount of oxygen they're pulling in. They're getting too much. Now they're getting carpal pedal spasms, lips are tingling, They have a sense of impending doom, feel like they're going to die. They need to slow their respiration down, and that's going to overall affect how they're feeling. It's going to become better, and hopefully that's also going to help dry up that panic attack. Depression, feeling of sadness, worthlessness, discouragement, a factor in suicide. Depression is definitely one of those things that can lead to suicide, especially those individuals that are bipolar. I think it's bipolar, where they're really, really happy at one moment and then they crash depression on the other side. That's where we see a lot of the suicide attempts and successful suicides in some cases. Flat effects, withdrawn, crying, changes in appetite or sleep, feeling of guilt, and decisions. Uh, so feelings of guilt and indecision, excuse me, these things, we're going to question the patient. We're going to ask for information, and we're going to find some of these things out. They're feeling guilty about something that happened in the past. They may be talking about, I can't sleep at all right now. It's just, no matter what I do, I cannot sleep. That's telling us we got to look at depression. Appetite becomes an issue, changes in, and a lot of times they talk about the lack of appetite. Definitely you're going to see that, but don't be surprised if you see the opposite, an increase in appetite, because they're trying to feed that depression and take it away. Bipolar disorder, change in mood from very elevated to very low. Manic phase involves abnormal, elevated, expansive and irritable moods, and elevated moods alternates with periods of normal or depressed moods. So these people, you've seen the commercials, I believe, where you get this person building a deck of cards house and they're at the top work in the middle of the night. They can't sleep. They're overactive. They're cleaning everything. They're into everything. They get over involved in everything. That's the hyperactive portion of this. That's the elevated moment of the manic phase of this bipolarism. But know that the manic phase, when it's done, you hit the normal phase, or you may actually tank to that depression mode, and that's where that suicide attempt comes in. Paranoia, exaggerated or unwarranted mistrust and a suspicion, delusions of persecution, maybe aloof, hypersensitive, excuse me. Behaviors can be unpredicted and aggressive. And so when we talk about these types of situations, paranoia specifically, aggression is something we got to be very careful of. These paranoid individuals think everybody's out to get them. And in that respect, if we're not watching out, we could very easily be put in a situation that the aggression comes out. And now we're stuck in a bad spot. Remember, this is scene safety. Look at what's your egress in and out. Make sure you pay attention to that carefully so that you know how to get out of the situation when it's time. So from paranoia, we go to schizophrenia, chronic mental illness, distortion of speech or thoughts, delusions, hallucinations, social withdrawal, catatonic behaviors, lack of emotional expression. This is a pretty bad one. This becomes that chronic illness. This is something they deal with constantly all the time. They're going to have that speech pattern that's distorted in some senses. It really doesn't make sense when they're talking. Never buy into hallucinations, and these people will have them. I've had people who say they see Jesus standing next to me, and I can't tell them, yes, he's here. I can't. I have to let them know, no, he's not here right now. I've had people who said they've got worms crawling out of their skin. I'm not going to buy into that. They do not see worms crawling out of their skin. It is not happening. It's hard to do because it puts them on edge, and it puts them in a very confused state. But we have to be honest with them as best we can. Violence and suicide. Common method of suicide includes gunshot wounds, hangings, poison by ingestion, and carbon monoxide poisoning. So, unfortunately, what we're discussing here is going to lead eventually to the possibility of suicide. And these are more of the common ways in which it happens. And I'll be honest with you guys, I've seen all of these and multiple times. I've been on plenty of self-inflicted gunshot wounds, both successful and unsuccessful. I've been on hangings, both successful and unsuccessful. I've seen plenty of poisonings by ingestion, taking in things they shouldn't be taking, pretty much just sleeping pills or Tylenol or antidepressant drugs, multiple handfuls of them. Carbon monoxide poisoning, I've been there. I've seen it, both successful and unsuccessful. People, die in their car. We have to be aware that if we've seen these people in the past, that they are capable of doing this. We respond back to their house a couple of weeks later for a similar situation. We need to be prepared. It may be the time they finally felt it was necessary to, attempt this. And will they be successful or not? We'll find out. It's just a hard thing to deal with. You have to be aware that this is what our job is, and we will come across these types of things. Violence and suicide. EMTs must take every suicide attempt or gesture seriously and transport the patient for evaluation. Patient-orientated times 4 is capable of telling you who they are, where they are, what day it is, who the president is, with no problem at all. They are clear-headed, totally with it. However, they have a map on the table that plans out everything about how they're going to take their life. They told you when you walked in the door, I'm feeling depressed. I feel like I want to die. I'm going to take all these pills. I've got the rope. I'm just learning. I'm Googling how to tie the noose. They have a letter written out. All these pieces are telling us that they have a plan. If they have a plan, we have to take them seriously. If they say, I want to hurt myself, I want to die, we take them seriously. This person, even though they're oriented times 4, does not matter. Okay. They are now our responsibility. This moves us into what's called the 5150. We as EMTs cannot place the 5150, which is a 72-hour state hold for psychiatric evaluation. We cannot place the 5150. However, we identify the need for the 5150. Call law enforcement, get them to the hospital. Those are the people that will put the 5150 in place. Risk factors and signs of potential suicide include the following: history of mental illness, previous suicidal gestures, history of child abuse, genetic predispositions, and feeling of hopelessness. All of these things right here are going to tell us that the potential for risk for suicide is pretty high. Next slide, please. There we go. Okay. Risk factors and signs of potential suicide include the following: diagnosis of serious illness, significant loss, ages 15 to 24 years of age, and 40 to 59 years of age. This is that area of higher risk for suicide. So when people are talking about it, we have to take them uber seriously because it's really going to happen. Alcohol or drug abuse, and divorce or widowed. And right now in the state of what we got going on, where we've got people who are out unemployed and incapable of taking care of themselves during this crisis, this is going to be something that increases. That's going to actually happen. There was I think it was in Irvine, I just heard on the news, was a murder-suicide pact that happened in a house. Because of, I would assume right now, because of everything that's actually going on. These are things that actually happen. We got to deal with. Next slide. Violence in others. Violent patient can be difficult to control. Violence can be provoked by actual or imagined mismanagement, psychosis, intoxication, fear, panic, phobias, paranoia, or head injuries. When these violent situations come out, we need to protect ourselves, take care of ourselves, but we still need to treat the patient to the best of our abilities. It brings us into the conversation of restraints. When do we actually restrain? Whenever somebody's endangering themselves or others, we have the right to restrain. Now, national registry-wise, we have to call to ask for permission. In the state of California, we have the right to place them in restraints if they're endangering themselves or others. Document it, because when you get to the hospital, the nursing staff, the doctors will sign off on it. National registry outside of here, you have to ask for permission. You're getting a signature, you're getting a permission online, recorded, then you can do the restraints. I'm pretty certain if you're in Montana and you have to make contact for a situation becomes very violent towards you and everyone around you, I don't think you have to make the call to before you start the restraints. I'm pretty sure restraints have been done. They make the call. Can we do it? This is why. Nobody's going to tell them no. I'm brainstorming thoughts here. The fact of the matter is, when a person is endangering themselves or others in these types of situations, we have the right to restrain them, to subdue them. Enough force to stop them, not to harm them, to stop them. That's what's important to remember. Signs of impending violence include nervous pacing. I'm sure you've seen stuff like this before. Shouting, threatening, cursing, throwing objects, clenched teeth or fists. And I've seen all these things, and you need to take them seriously, respect them, because things will go sour very fast if you're not careful. Next slide. Okay, we're going to stop here, guys. Appreciate you watching through this with me. We're going to move on here in a little while with dealing with behavioral emergencies. I'll work on that video soon. So this is how we're going to try and do this from this point forward. I know this is unusual. I appreciate your effort and being willing to stick around and go through this with us. I think that we can make this work for the better. And when this COVID-19 thing is all under control, we can move forward with you guys and get you to where you need to be, okay? With that being said, guys, I appreciate you being here. Thank you very much for paying attention, and I'll talk with you soon. Bye.